Okay, well, good morning, everybody. And I would like to start by thanking the organizers for giving me an opportunity to talk to you today about one of the topics that's very close to my heart and that has received a lot of updates in the last 10 years. So we felt that it would be a really good topic for these teaching rounds. So I'm going to be talking about idiopathic inflammatory myopathies. And as you have heard, we will go over the specific objectives in a moment, but I wanted to start with these financial disclosures. I do receive research support from Odantis Therapeutics for my work in neuromuscular disease field, but with a particular emphasis on metabolic and congenital myopathies, so not really relevant for the topic of today's lecture. And then these are the learning objectives that you have already seen. So we'll be going mainly over the new classification of idiopathic inflammatory myopathies and how that will, how you need to apply that in your daily work. So we'll start by just talking about inflammatory very briefly, just saying that there are different kinds of inflammatory myopathies. Not all of them fall into the category we'll cover today. But in terms of what you might see as a biopsy specimen on a neuromuscular surface, this is indeed the most common type of muscle biopsy. And indeed, with increased access to genetic testing, which has sort of changed the profile of cases that we see, these are constituting a larger and larger proportion, at least at UCSF where I work, of the biopsies that we see. So most of you who are not neuropathology fellows currently training have learned this old classification. That's certainly what I have learned when I was a fellow of these idiopathic inflammatory myopathies. So there were basically these three categories that we use: dermatomyositis, polymyositis, and sporadic inclusion body myositis. But in the last 10 years or so, with discovery of so-called myositis-specific antibodies and deepening understanding of their role in these disease processes, the classification has really changed pretty drastically. So now we have the four categories that you see on top here, and we'll talk about each of them in more detail. And then we still have sort of polymyositis. It has not been completely eliminated from the classification, but most people feel that either it's very, very rare, or possibly that it doesn't exist, and that even those few cases that we might still call polymyositis would actually be better classified as one of these other disorders. And I think that's one area that still remains to be elucidated. But either way, it is a very, you should not be having that as a diagnosis that comes up very often. So how did all of this change, right? So as I said, instrumental piece was the discovery of these myositis-specific antibodies and their role. And some of these antibodies have actually been discovered pretty early on. You can see that MI2 antibody, the discovery dates all the way to 1976. But with the exception of antisynthetase antibodies that are here in this teal green, all the other ones were sort of sporadic. So this is one antibody associated with dermatomyositis. This is one associated with immune-mediated necrotizing myopathy. And that was not enough to kind of recognize the pattern. And it's really here in the 2000s that we discover more of the antibodies and start really realizing how those things fit together. And once that happened, then it took about next 10 years to sort of incorporate this into these changing criteria. But eventually, sort of at the end, so starting from 2017, as you can see here, there is like a lot of activity, and we emerge with these new criteria that I'm going to be talking about today. So this is a nice figure from the paper by Dr. Hunter Kai and collaborators, and they sort of plotted the data that actually come from a different paper, from this paper by Suzuki, published in 2017, where basically, that was one of the larger studies that basically contributed to this reconceptualization of these categories. And so I think the specific numbers here obviously will slightly vary with cohort, and might be, as we learn more, even maybe slightly revised. But I think the big picture here is that we have this category here, immune-mediated necrotizing myopathy, that we didn't even have 10 years ago. And this category, is 40% of the cases. So what did we call these cases in the past? Like, well, how did we miss such a big category before? And that's one of the things that we're going to be talking about today. So this is one way to kind of reconceptualize what happened to these categories, right? So this is what we used to have in the past, and two of these are still with us: dermatomyositis and sporadic inclusion body myositis. And sporadic inclusion body myositis is really quite distinct clinical pathologic category. So those cases mostly stay those cases, although perhaps we're including some that we used to call polymyositis as well. And then, dermatomyositis, some of those cases stay dermatomyositis, but others are now recognized as antisynthetase syndrome-associated myositis. And finally, the ones that we used to call polymyositis, essentially most of them went into this immune-mediated necrotizing category. Some of them are probably early stage of sporadic inclusion body myositis, and then probably less commonly, some went into this category of antisynthetase syndrome-associated myositis. Now, one big difference between these two categories on the right and the two categories on the left is that these tend to be muscle-specific diseases, meaning usually you have only the weakness as a main part of clinical presentation there, and there's very rarely and usually no involvement of other organ systems, whereas the two disorders on the left could actually be thought of as systemic disorders. They generally involve at least skin and skeletal muscle and sometimes other organ systems as well. So I'm going to start this lecture with these categories on the right because they're a little bit more straightforward actually, and then we're going to end with these two categories on the left because they're more complicated. We're going to start with immune-mediated necrotizing myopathy, the category that, as I said, it didn't even have on the books until 10 years ago or so. Now, this is the first one of some of the very verbose slides I have. The reason I put a lot of information in, a lot of text on the slides is that if you want to use these slides as a reference later when you're signing out, you have that as an option. So it's a pretty decent summary of the literature, but I'm not going to go through every line that's on every slide. So anyway, currently we have two antibodies that are associated with this clinical pattern that we know, but 1/3 of cases is currently seronegative. Now, they're thought to involve the same mechanism, and so it's just a matter of time, I think, when we'll discover the actual additional antibodies that cause this phenotype. But as a practical matter, about 1/3 of cases is seronegative. And these are the most likely cases that come to biopsy, because strictly speaking, by the current criteria, if you have the appropriate clinical phenotype that matches this, and you detect one of these two antibodies, you wouldn't actually have to do a muscle biopsy. We sometimes still get them because some of these tests take a while, and sometimes the muscle biopsy will give them the answer earlier than doing the serologic testing. But I imagine these numbers will come down. So these have recently been shown to actually be mediated, through a type 2 immune mechanism. So they involve direct antibody and complement mediated damage to muscle fibers. And so this is really a humoral type of autoimmunity, which is why these don't have many inflammatory cells, and which is why we didn't recognize many of them as inflammatory myopathies before this new classification. They don't have skin findings, and the CK levels are usually quite high. So the top part of this slide goes over the key histologic features, and I'm going to show you those on figures. But I would like to, or the next slides with the images. But I think I would like to highlight this main histologic features, which is that we have degenerating, regenerating fibers that are randomly distributed and without much inflammation, which is why this was so difficult to recognize as an autoimmune disease to begin with. So because of that, one of the main differential diagnoses that you may have looking at the muscle biopsy is actually toxic or metabolic necrotizing myopathy. Rarely you consider other inflammatory myopathies. Usually that differential is not so difficult. And then if it has been present chronically and not recognized, it can actually mimic muscular dystrophy again if you're not thinking about it, because again, there is not much inflammation and you might see chronic myopathic changes. So here then is what an immune-mediated necrotizing myopathy looks like. So on this is a frozen H&E, and you're seeing essentially these degenerating fibers like the one here or the one here, or some of these here. So you see different stages of degeneration and then regeneration. So here is the regenerating fiber, and another one here. And the key thing is you may have macrophages associated with degenerating fibers, but there is a very sparse inflammation otherwise, sometimes none, sometimes very little lymphocytic inflammation. So basically, it just looks necrotizing. And if that's all you have and you don't have additional markers that I'm going to show you on the next few slides, you actually wouldn't be able to go further than that. You would have to say that this is a necrotizing myopathy and then provide the differential that it could be toxic, it could be metabolic, and it could be immune mediated. But if you have some additional stains, in many cases, you can go further. So one of these extra stains is MHC1, that's shown on the left. And this is not always upregulated in this condition, but it often is. It's sometimes diffusely positive, as in the case I'm showing here. Sometimes it's patchy, but it's generally going to be more positive than in a toxic or metabolic necrotizing myopathy. And then even more helpfully, although again, not present in every single case, you can see complement deposition both in the muscle fiber membranes, as you can see here, and in the endomysial capillaries. And if you have these two, or even really just one of them, you should be pretty comfortable in calling this an immune-mediated necrotizing myopathy. But what really helps in difficult cases are these two additional stains, or at least one of them. They give very similar results, so you could really use either. And these are autophagic markers LC3 and P62. So you will see these stains are useful in some of the other conditions we'll talk about as well. But they give a very different pattern of staining. And so it's really this difference in the pattern of staining that's helpful. So in these immune-mediated necrotizing myopathies, for the reasons that we still don't really understand, we get this finely punctate pattern that's very characteristic. It can be few fibers, it can be quite a few, like in this case here. And again, the LC3 stain and the P62 stains seem, they look very similar. So you can really use either one, whichever one is available at your institution. And that can be really helpful in some of the tricky cases. Here is the EM correlate to this. And so instead of large autophagic, well-developed autophagic vacuoles, you're seeing these small accumulations of autophagosomes and autophagic debris. And so this is the correlate to these fine LC3 and P62 positive puncta that you can see by immunohistochemistry. As I said, there are currently 3 subtypes depending on the antibody or the lack thereof. And they have slightly different features that are summarized here. But for the most part, it's very much overlapping, and you won't be able to tell which one it is based on histopathology, or really even strictly speaking on the clinical findings that you will generally need to do serologic testing to identify which antibody it is. The seronegative ones are the most likely to be associated with cancer, so to be a paraneoplastic phenomenon. And we have seen at UCSF now several cases that are coming up in the context or secondary to COVID-19 disease. So I will now move to sporadic inclusion body myositis as the second disease that we'll be talking about. So in this case, we have one myositis-specific antibody, and even that, so anti-CN1A, and even that is present in only 50% of cases. So there is actually less of an antibody role in this disease than in the other ones that we're talking about today. The mechanism for this antibody is unclear. It may just be an association and not really etiologically relevant. In contrast to immune-mediated necrotizing myopathies, for which I already told you, the antibodies are actually causatively related. They cause the disease. So in this case, there is some genetic predisposition, both in terms of autophagy genes and the HLA genes, and that actually hints at the 2 components to this disease that we have struggled for quite a long time to really understand how they fit together. So there is an inflammatory component, which is why this is classified as an inflammatory myopathy. But there is also a myodegenerative component where, essentially this looks somewhat like a muscular dystrophy or, has basically these chronic myopathic changes as well as accumulations of different proteins and really prominent autophagy impairment. So this has sort of led to these two views within the field, what is the chicken and what is the egg? And the consensus is emerging that it is the inflammation that drives this disease, even though this disease, in contrast to every other disease that we will talk about today, does not respond to immunosuppressive therapy. And this lack of the response to immunosuppression was the issue that was always saying, maybe the inflammation that we see here is secondary and not really important. But quite recently, in maybe 2 years ago, there were several papers that showed that there are these terminally differentiated or exhausted T cells that play a role in sporadic inclusion by dermatomyositis, and these cells do not actually respond to steroids by undergoing apoptosis. So this perhaps explains why this disease is resistant to treatment. But anyway, it's thought that this prolonged inflammation that is sort of dysregulated ultimately leads to myodegeneration and dystrophic features that we see in this disease. And this is really, as opposed to all the other diseases that have somewhat overlapping clinical presentation, this is fairly unique. Instead of symmetric proximal weakness, we tend to have asymmetric weakness, and that particularly involves knee extensors and finger flexors. The CK elevation is generally not very high. And even though this can happen secondary to systemic inflammatory disease, most of the cases are occurring sporadically in people that are over 45 years of age. Now, here is the spectrum of histologic findings that you can see, and I kind of lay them out here in terms of the way we understand the progression of this disease right now. So these two things on top, if that's all you have, that's what you would still call a polymyositis. Now, it's actually, again, pretty rare that you have only that and none of these other findings. But that, strictly speaking, would still, by the current criteria, be called polymyositis. And then the moment you get these additional mitochondrial abnormalities, so regular red fibers and COX-negative fibers, you are now in the category that we would call polymyositis with COX-negative fibers, and that is quite definitely understood as a precursor to IBM. So whereas this condition on the top, just polymyositis by itself, is not really clear, whether that would also progress to IBM or not. Once you have the COX-negative fibers and regular red fibers, then it's pretty clear that you're on the path to IBM. Then the things progress generally, and then you start getting chronic myopathic changes as well, so things that look like dystrophy. And then finally, you start getting the features that make it a definite IBM. So that's when we get the rimmed vacuoles, protein aggregates, and tubulofilamentous inclusions on electron microscopy. What remains to be elucidated is this a treatment responsiveness horizon? In other words, it is known that once you get to this phase with mitochondrial abnormalities, that the disease is already not responsive to immunosuppression. What is not clear now that we have revised the criteria and we have taken all the other diseases from the polymyositis category, it's not clear whether this, what remains here, will be treatment responsive, or is that already an IBM precursor and it's not going to be treatment responsive either. So here is how it's a classic case IBM that we're going to go over here, some of the findings. So here is endomysial inflammation that consists of T cells and macrophages. And you can see that's one of the key diagnostic findings, invasion of an otherwise intact muscle fiber by these inflammatory cells. So if you have that, that is very helpful. That would not be, for example, an immune-mediated necrotizing myopathy. And then this slide here highlights the chronic myopathic features that develop in this disease over time. Obviously, but usually they're present by the time you get the biopsy because the disease has subclinical course. And here's a lot of fiber size variation endomysial fibrosis, fatty infiltration, and so on. Now, one of the key findings that used to be required for the diagnosis, and it was very specific but not very sensitive, is the presence of rimmed vacuoles. And whenever you have rimmed vacuoles, that means that you have autophagic impairment, either genetic, drug-mediated, or in this case, secondary to inflammation. But so by themselves, they don't mean that you have sporadic inclusion myositis. You have to have these other features, including inflammation and MHC1 positivity. But these are the rimmed vacuoles seen on H&E on the frozen specimen and seen on the trichrom on the right. And you can bring them up either in the frozen sections or, for that matter, in the paraffin embedded sections by using these autophagic markers LC3 and P62. So that tends to be, again, very helpful because otherwise you don't see them on the paraffin embedded material. And here are the rimmed vacuoles that are highlighted by LC3. And I hope you're appreciating how different this looks from the pattern that we have seen in the immune-mediated necrotizing myopathy. And here is P62 again, looking very similar, highlighting the rimmed vacuoles, as well as these coarse sarcoplasmic inclusions and protein aggregates. Here is a TDP3 stain that is also very helpful, and that tends to appear pretty late, but then it's very specific in the right context for IBM. And so here, this is this is, of course, normally nuclear protein, and pathologic finding is when it's present in the sarcoplasm. You have here these fine puncta. Here, some of the coarser aggregates. You can also see rimmed vacuoles as well. Here is, by the way, the correlate to the rimmed vacuole on the EM. And here you can see this autophagic rim, which is why this is positive at LC3 and P62. And then in the center, you can see this inclusion or inclusion body, which is how the disease got its name, that's largely composed of these tubular filaments. So we'll move now to the second two categories, which are more complex in the sense that they're not muscle-specific diseases anymore, but they now also include other organ systems. And so the first one in this category that we're going to go over is the antisynthetase syndrome-associated myositis. So as the name suggests, this is the syndrome or the type of myositis that's associated with antisynthetase antibodies. And the most common one, and the one that was first discovered, is the anti-Jo1, but there are others, these four here, as well as some of additional ones. And we don't really understand the pathogenesis of this particular disorder very well, but it does seem to be centering on the connective tissue inflammation. And perhaps as a result of that, you have definite involvement of other organ systems here. So you do have skin, and the skin findings somewhat overlap with dermatomyositis findings, which is why these two disorders used to be lumped together. But you do have very, very frequently association of interstitial lung disease. And then you can have some other systemic symptoms like joint involvement, fever. So this is much more of a systemic inflammatory disorder, just with the pretty prominent skeletal muscle involvement. Here are the key histologic features. And I would highlight here the second point, or the second bullet point here, the perimesial pathology. So we have this prominent edema, fragmentation of perimesium with macrophage-rich inflammatory infiltrate and with linear alkaline phosphatase positivity. And you do have perifascicular fiber involvement, but rather than just having perifascicular atrophy that we're going to talk about in dermatomyositis, you generally have perifascicular fiber necrosis. But here, this perifascicular fiber involvement is thought to be secondary to this perimesial pathology, right? Rather than sort of capillary pathology that seems to drive dermatomyositis. And so another name for this that was proposed by Alan Pastrong from WashU, but didn't in the end catch on, was a purely histologic name. So inflammatory myopathy with perimesial pathology, that's basically the same thing as what we're discussing here, just a different name. And so histologically, this is pretty distinct, but there is one particular variant of dermatomyositis, as you will see at the end, that can have quite similar features, and that's really the main differential diagnosis once you have this pattern, if you don't have the antibody result. So here is an example of antisynthetase syndrome-associated myositis. Here you see perimysium, that's again sort of edematous, fragmented, and has a lot of macrophages. There are also some lymphocytes, but macrophages are pretty common, or particularly common. And then, perifascicularly, you have atrophy, but you also have fiber necrosis. And the fact that you have fiber necrosis is a clue that you might be dealing with antisynthetase syndrome-associated myositis. Although, again, anti-MI2 dermatomyositis has quite a bit of overlap, and that's one of the most difficult differential diagnoses in this particular field. So here are these additional stains that can be helpful. Here on the left, we have MHC1. It tends to be diffusely upregulated, although more so in the perifascicular areas. And obviously, it also stains macrophages, so it will stain a lot of these cells in the perimysium. Here is the complement, and complement tends to be more in the endomysial capillaries in these areas adjacent to the inflamed perimysium, rather than diffusely. It will also highlight these necrotic fibers, so that's another helpful feature. It also has, which I'm not showing you here, but this linear alkaline phosphatase positivity in this inflamed perimysium. Here are two stains that are helpful when you're trying to differentiate this from anti-MI2 associated dermatomyositis. So one is MXA, and we're going to talk more about MXA stain when I get to the dermatomyositis section. But the point is that here it is not significantly upregulated, not in muscle fibers and not in the endomysial capillaries. Now, what makes this a bit difficult to interpret is that it is positive in inflammatory cells, and there will be quite a few inflammatory cells here. So it's not the easiest of interpretations, but nonetheless, this should be negative. And then a positive finding is the presence of these nuclear actin inclusions that you can detect by EM. And this is very specific, but not sensitive, right? As you might imagine, because you're using EM and you're looking for these nuclear features. But if you are in doubt, that would be a helpful test to do. If it's positive, it rules in antisynthetase syndrome-associated myositis. If it's negative, it doesn't really rule it out because of the sensitivity issue. And then that we will move to our final category today, which is dermatomyositis. Now, I left this for the end because there are 5 antibodies that are associated, and each of them has slightly different features. So this is in contrast to everything that we've discussed before, where, for example, in antisynthetase syndrome-associated myositis, the features are the same regardless of the antibody. Although one thing that I haven't emphasized in that section is that anti-Jo1 tends to have more myositis and less interstitial lung disease, and some of the other antibodies, it's the other way around. So the features can be milder with other antibodies than anti-Jo1, but they're of the same kind. And likewise with immune-mediated necrotizing myopathies, as I said, the histologic findings and even the clinical findings are not that different depending on the antibody. But here with dermatomyositis, things are quite different. And this is really best understood as a spectrum, because each of these antibodies actually has somewhat distinct clinical pathologic features. So you can use this to impress your clinicians, because you should be able actually to sort of, just based on histology, often to classify it in one of these specific, you could guess what the antibody would be just based on histology. But on the other hand, it makes things more complicated, of course, because now you have to know all of these different features and to recognize that these still fall into the same spectrum. And you will see that some of these are quite different from what you might expect when you have dermatomyositis in mind. Now, one thing that does tie these together and says they are all part of one spectrum, or they share the similar disease mechanism, is that they all show activation of interferon alpha beta or interferon 1 response. And we can use that marker MXA that I mentioned before to kind of as a readout for this particular response. So that's why that antibody tends to be very useful in dermatomyositis cases. Here are the sort of shared clinical features, but again, they will depend on the antibodies, so they are not going to be always present. And so the entire clinical pathologic pictures is antibody specific. So again, here the shared features that I think is what most of you think when you think about dermatomyositis. But again, some of them may actually not be present, as you will see in a moment. And so really the only thing that's present across all of these conditions is MXA or really this interferon type 1 response that's present in all of them. And then the histologic differential diagnosis varies depending on where on the spectrum you are and what antibody you have. And that's highlighted in this slide here. So the three antibodies that we have here in the middle is what I think everybody would recognize as a typical dermatomyositis in terms of the histology. But these two antibodies that are on the left and on the right are quite different and might be actually difficult. So as I mentioned a few times already, the anti-MI2 looks a lot like antisynthetase syndrome associated myositis, and anti-MDA5 actually looks like immune-mediated necrotizing myopathy or even a normal muscle. So those can be quite difficult. But here we're going to briefly go over the categories, these 5 different antibodies and how they differ. So anti-MDA5, when we look at the muscle, you might think, oh, this is a very mild disease. And indeed, the muscle involvement is mild. But this is a very severe disease. The skin findings are severe. The interstitial lung disease is severe. So from the patient's perspective, this is not a good disease to have. And really, histology is quite underwhelming. There is no perivesicular atrophy, no inflammation, maybe mild MHC1 upregulation, and then this mild MXA upregulation that can really help classify this as dermatomyositis. With anti-SAE, it's more of a typical dermatomyositis pattern, but it can be very patchy and mild. And so this is maybe a setting where you have normal histology, but then you just pick up like perivesicular MHC1 upregulation and perivesicular MXA upregulation to sort of clue you into the correct diagnosis. So typical findings, but can be patchy, and so the muscle can look normal even if the patient does have this disease, if you don't happen to, if you have a sampling error, essentially. This anti-TIF1 gamma is the most typical one. This is the one that I would choose if I was giving this lecture to medical students, because this is what we, when you say dermatomyositis, this is what you think about. So this is the condition where you have very, very well developed perivesicular atrophy without much inflammation. Really, this pretty much checks all the classical boxes, including strong cancer association. One thing that's unique here is that you can have vacuolated perivesicular fibers. And so if you see that, that can sort of clue you into what the antibody might be involved. Here is the anti-NXP2 dermatomyositis. This is a most common antibody if you have juvenile dermatomyositis. You can have some of these unique clinical features like calcinosis and severe edema. And here, the unique histologic feature is the presence of microinfarcts that you can have in these perivesicular areas, but otherwise also looks pretty typical for dermatomyositis. And then finally, the one that I have mentioned quite a few times already is this anti-MI2 dermatomyositis, perhaps because of this overlap with antisynthetase syndrome, or perhaps for some other reasons, but we have been lately at UCSF seeing this as the most common one. I have had relatively few other types recently, but this is the one we see most often in terms of the biopsy. And it's an important distinction from antisynthetase syndrome associated myositis, because here the interstitial lung disease is actually uncommon, whereas it's almost invariably present with antisynthetase antibodies. And the features here are pretty similar to antisynthetase syndrome associated myositis, including the fact that you can have perivesicular fiber necrosis, that you can have a lot more inflammation than in other types of dermatomyositis that you can have some patchy alkaline phosphatase positivity and fragmentation of perimysium. But as I said before, in this case, we should have MXA upregulation, and we should not have those nuclear actin inclusions that we have in the antisynthetase syndrome-associated myositis. So here is a nice figure from paper by Gentima Temboon and collaborators, where they sort of highlighted these different features. So these are some of the common things that you can see across most of these, except from anti-MDA5. So perifascicular atrophy, loss of COX SDH activity in the perifascicular areas, MXA mostly in the perifascicular areas, and then here is the neonatal myosin, so which is a marker of regeneration, and you can see that primarily in the perifascicular fibers. And here are some of these unique features that we see. So here, the vacuoles that we see with TIF1 gamma, microinfarcts with NXP2, alkaline phosphatase positivity in the perimysium, and necrotic perifascicular fibers in anti-MI2. And then here, anti-MDA5, which basically looks like normal muscle here, but we do have this MXA positivity that's not even perifascicular. Here are two examples now from UCSF. So here, again, a classical case with perifascicular atrophy, and you can see this perifascicular vacuolization. So that's anti-TIF1 gamma. And here is what the MXA pattern looks like. So very nice perifascicular staining with upregulation in muscle fibers. Here, on the other hand, to kind of compare and contrast, is anti-MI2 case. And you can see again that it involves perifascicular areas, but there is a lot more inflammation. There is again that sort of paleness because of edema to the perimysium. And then, inflammation and perifascicular fiber necrosis. So again, occasionally difficult to differentiate from antisynthetase syndrome-associated myositis. And here is the MXA, which unfortunately in this setting doesn't seem to be upregulated in muscle fibers so much, which would be really helpful if it were, but mostly in the endomysial capillaries. So you have to sort of look hard to differentiate that from the positivity in the inflammatory cells, which are basically a distractor. And with that, we're going to move to look at our virtual slides. We're going to go hopefully over 2 cases before we move to the Q&A session. So I will have to unshare here and basically share a different screen. All right, so we're going to go through 2 cases. I have provided for you quite a few slides for each case, and we're probably not going to go through all of them for the sake of time and to allow enough time for questions. But you can then, if you wish, look at these later on your own. I'd just like to point out here, maybe you already know that, but I have found that Path Presenter, where these slides are, doesn't work for me when I'm in my office. It seems that the UCSF firewall is blocking it. So if you try to access these slides and you can't, maybe you can try again from home. Maybe the institutional blocking software is to blame. So anyway, this is case number 1, and this is the actual clinical history for this case. So 78-year-old woman with progressive weakness for 4 to 6 months, with dysphagia, dysphonia, on statins, with marked proximal weakness, head drop, and pretty high CK level, 4,000. Okay, so now my Zoom controls are blocking my slide advancing controls here. Let's see if I can. That will be a little bit tricky. Okay. Maybe I have to exit.
Can you try hitting the arrow on the top row, like
Yeah, and my problem is that the Zoom bar is covering my.
Oh, you can't see it.
I can't, see them.
Sometimes you can drag the Zoom controls down to the bottom if it'll let
you. Oh,
you.
yes, thank you. Perfect. Wonderful. All right. Thank you. Okay, so here is the formalin fixed paraffin embedded H&E. And what you should notice is that we have a lot of regenerating fibers. Here's a nice example of a regenerating fiber. There are many others. Degenerating fibers, here's the one that's undergoing myophagocytosis. So you will generally see this type of pattern with different phases of degeneration and regeneration across. And there is some inflammation, again, because you do have this macrophage assisted fiber repair, but not too much in terms of lymphocytic inflammation. So this is sort of a classical pattern, in this case on a pretty severe end of things, of a necrotizing myopathy. And here we have frozen H&E, which is a bit dark on this scan slide because of the thickness of the slide. But essentially the idea is that, here, this was a little bit more severe than some of these cases. And you can see already some degree of chronicity. So you see a little bit of fibrosis, you see a little bit of fiber size variation. Often that's not present and you only have a pretty unremarkable background muscle. But here it does hint that maybe this patient has had this problem for longer than it was clinically apparent. But otherwise, you're still seeing mostly just regenerating fibers and not too much inflammation. Here, again, is MHC1. And so you can see here that it's quite diffusely positive. There are some, these regenerating fibers are staining particularly strongly, but you also see diffuse upregulation in muscle fibers otherwise. Here then is the complement. And as I said, complement has two useful purposes. For one, it will stain all necrotic fibers very strongly. Now, most of the time you don't need that for that purpose, but sometimes if you have a muscle with a lot of artifacts and you're wondering, are these really necrotic fibers or not? This can be a helpful feature. But what we're really looking for here is this upregulation in muscle fibers as well as in deposition in endomysial capillaries. And again, in this case, it's very strong and diffuse. Not all, sometimes it can be patchy, so you don't have to have it this well developed for diagnosis, but sometimes it is, and then it's obviously a slam dunk. Here is the LC, or this is actually CD8 stain, and so you can see here that even though we didn't appreciate a lot of lymphocytic infiltrate on H&E, there are scattered inflammatory cells present, and these tend to be CD8 positive T cells, as you can see here. But not as many as you might see in other inflammatory myopathies. And then, as I mentioned before, this is the LC3 stain. So here you can see this really strong staining, these fine to coarse puncta that are diffusely present in muscle fibers. And again, this doesn't have to be this fulminant as in this case, but the pattern of staining is pretty unique for this particular condition. And here is P62 that looks essentially the same. So basically the diagnosis here then is an immune-mediated necrotizing myopathy. And indeed, after the biopsy, this patient turned out to have anti-HMG-CoA reductase antibodies. So this is an example where we already had a little bit of this chronicity. And you can see how maybe if this has lasted longer and in a different setting, you might have possibly even misdiagnosed this as a muscular dystrophy if you didn't have all these ancillary tests to sort of clue you into the right diagnosis. Here is case number 2. This is a 61-year-old woman with progressive muscle weakness that, according to the history, started rather rapidly 1 year before. The biopsy, they didn't really provide us with much in terms of the neurologic exam results, but we do have CK that's less than 1,000. And in this case here, you will appreciate that these chronic myopathic features are much more prominent, much better developed. You have fatty infiltration and prominent variation in fiber diameters. Obviously degenerating, regenerating fibers, but then also you do see more lymphocytic inflammation. And as you will see later, when we get to CD8 stain, you can actually see the fiber invasion. Here is the frozen H&E, which basically shows the same findings, but in addition, you can see rimmed vacuoles. And for the sake of time, I'm not going to be going around this a lot, but there are actually quite a few rimmed vacuoles. And here is another fiber with very nice rimmed vacuoles. So basically, we have endomysial, T-cell based and macrophage based inflammation, chronic myopathic features, rimmed vacuoles. So this is basically inclusion body myositis. Here are some of the additional stains. So this is SDH, which I'm going to skip for the sake of time, but I'm going to show you the COX. So these days we do combined COX SDH stain because it makes it easier to recognize COX negative fibers. But this case was from an earlier time when we didn't do that, but you can still see many COX negative fibers. So again, one of the features of inclusion body myositis is the presence of these secondary mitochondrial abnormalities. So then here we have MHC1, which is basically diffusely positive. Here is the CD8, and you can see that we have a lot more of these CD8 positive T cells compared to the prior case. And we can see pretty prominent, in some cases, you can detect areas where there is invasion of muscle fibers. And then finally, the autophagic markers. And so I just wanted to highlight again the difference in the pattern from what you have seen in the prior case. So this is also positive, right? But now we're seeing this prominent staining of rimmed vacuoles and inclusion rather than staining, rather than fine punctate dense staining that you have seen in immune-mediated necrotizing myopathy. And then here is TDP43 that basically shows essentially similar findings with these puncta as well as coarse sarcoplasmic inclusions that we have here. So this I'm going to skip now for the sake of time, but this just compares side by side these two LC3 patterns and how they differ in these two different conditions. And these are some of the useful references. And now we can move to any questions that you might have.
Thank you, Dr. Margeta. That was fantastic. At this time, we'll move into Q&A. You may submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner. Once you've asked your question, please remute to avoid background noise. Okay, so I'm going to go ahead and read the first question. For the teaching of medical students and the purposes of their board exams, should we use the old system, PM, DM, IBM, or the system presented here?
Yes, well, that's a great question. I mean, certainly for our medical students, I use the new, I don't go into anywhere near this level of detail that obviously that I presented here, but I have switched to the new classification. So I talk about immune-mediated necrotizing myopathy and not polymyositis. I mean, hopefully the boards will catch up. I don't think that there are many questions about this area to begin with, fortunately. But, it just feels wrong to me to teach them inaccurate things, even if they're still in the boards. I mean, at the end of the day, they will be practicing physicians soon, and that's more relevant than getting, an outdated board question exam, right? So.
What is the value of TRI, tubulo-reticular inclusions, compared to MXA?
I always found the inclusions not incredibly helpful. The current criteria don't rely on them at all. And I have to say that, I didn't see a lot of literature. How would they help differentiate antisynthetase syndrome associated myositis from dermatomyositis, which is typically the question. Usually you're not really trying to differentiate them from these other conditions, but usually these are the two that have skin findings, and can have somewhat of an overlap. I would say that the current criteria very much lean on MXA, and just like in general, I find immunohistochemistry to be considerably more helpful than EM. I like EM and I still do it a lot, but it does have the sensitivity issue, right? Because you're looking at a very small part of the specimen. So whenever I can have an antibody test, I tend to sort of lean on that more heavily than on EM.
Okay. And then next I have a question from Shanu Romer. Hello, Dr. Margeta. Which C5b C9 antibody do you purchase?
That I would have to, that I don't know from the top of my head. So maybe if, that person would email me later, I can, send them the information. But the antibody we have works really robustly, basically, and we have never had a challenge with it. That's in contrast to MXA. So, one thing I do find it very helpful, and we have it. At the same time, it is a little bit more of a finicky antibody. So certainly the C5b9 antibodies and MHC1 antibodies are much more robust. So.
Okay. And then from Eddie Lee, he says, excellent talk. Do we know what the tubulofilamentous inclusions are made of in IBM?
Not that I know of. That's a great question. And it would seem that should be known, but a lot of people feel that these are nuclear, like degenerating myonuclei that are captured in these, but what the filaments are is a separate question that I think has not been given that much interest. I think there has been a lot of investigation into the inflammatory component, into the autophagic impairment component, less so in what those inclusions might be. There are a lot of people do a lot of mass spec these days and are finding different, very specific proteins in, when they cut out the inclusions and then they do mass spec just on their end vacuoles. So you get different proteins. Which of these are relevant for these filaments? That's a different question.
Okay. And the next question, thank you very much. Do you use, or should we even worry about CD4, CD8, and B cells in the differential diagnosis?
Yes, so I do use them. Most of these have primarily T cells and primarily CD8 positive T cells. So I do use, I typically do CD3, CD8, and CD20. CD4 I find less helpful because it will also stain macrophages, and you always have macrophages. So it just kind of gives for a little bit of a messy picture. But I do like to do CD3 and CD8. And then, whatever is not CD8 is CD4, basically kind of by subtraction. CD20, I do. Most of these cases have very little in terms of CD20 positive infiltrates. So if you do get quite a bit of it, I think that's when you may want to start thinking maybe about systemic inflammatory disease, where this is just sort of like a secondary inflammatory myopathy and not really fitting in any of these sort of primary or idiopathic categories. I have occasionally seen a case where it's actually a B-cell lymphoma that then sort of, or a plasma cell lymphoma, plasma cell neoplasm that's driving the kind of secondary inflammatory process. So I think CD20 is still helpful, but is not playing heavily in these criteria. The one condition that tends to have most CD20 positive cells is the anti-MI2 positive dermatomyositis.
Okay. And the next question, in your day-to-day practice, how often is histology and IHC enough versus how often do you do EM?
I would say for this group of conditions, almost all IHC. We don't really do for. I showed you the classic finding for IBM, but we rarely, do it almost never. Basically, all the other features that I mentioned, I find to be enough. One place where it does play a role is when I encounter this difficult differential of anti-MI2 versus antisynthetase syndrome. And some of the anti-MI2 cases do stand out with having less inflammation, less alkaline phosphatase positivity, and so on, and are not that difficult to tell apart. But sometimes it can be quite severe disease on the anti-MI2 spectrum, and it can be really a dead ringer for antisynthetase syndrome associated myositis, and that is the setting where I would do EM to look for these the actin nuclear inclusions basically that are present there.
Okay, and next, Marta, great to see you. I'm not sure who this is from, and very helpful and educational talk. In the ASM entities, are the actin inclusions thought to be due to weaknesses in the nuclear envelope, allowing invaginations of sarcomeric material?
So these are absolutely spectacular questions, and I have to tell you that I don't think it's known. Again, this was sort of described as a phenomenological level, like it is present. And interestingly enough, if you go to some very old muscle textbooks, people have seen these, and I have seen them described as part of the dermatomyositis spectrum. We of course now know it's not actually dermatomyositis, it's this antisynthetase syndrome associated myositis, but I can see how they would have thought that at the time, right? So it's not that these were not seen before. It is more recently that they were recognized as kind of unique / specific for the antisynthetase syndrome associated myositis. How they get there is a great question that I have wondered about myself. I don't know that this has been explored, certainly not in the studies that have just established the diagnostic utility. I don't think we really understand how these end up in the nucleus, but the question, the suggestion that the person that asked the question made is a very interesting one. So.
Okay, and it just came up in the chat. That was Ann Buckley that asked that question.
Okay, well, there you go, Ann Buckley. Ann was one of my very first fellows, so glad to, Ann, to have you come up with such a great question, so, and the hypothesis.
And then next I have a question from Juan Bilbao. Is there any use for Congo red staining for the diagnosis of IBM?
I don't find that very useful. There are all these other stains that are incredibly helpful. This was never very sensitive in, my feelings. So I rely heavily, like the overall histologic picture on the presence of the muscle fiber invasion, on the fact that we have the MHC1 positivity. That basically tells you that you're not dealing with an inherited genetic inclusion body myopathy, which would obviously be the key differential diagnosis in that setting. So presence of MHC1 and inflammatory infiltrate, that puts it in the inflammatory category. And then, I then rely mostly on having these chronic myopathic features, rimmed vacuoles, and then on the immunohistochemical level, LC3 and or P62, and then TDP43. These are the main things I use there, but I find Congo red not to be very helpful.
Okay, and then unfortunately, I don't think we're going to have time for too many more questions. Maybe I'll just ask one more, last one. This is from Dmitry Kapitanov. Hello, Dr. Margeta. Does C3b earlier step in the alternative complement cascade mimic C5b9?
That I don't think has been sufficiently investigated. I think at some point I recall maybe some folks starting to study this, but I haven't seen a lot of studies in this respect. And I think that may just be because a lot of us in the muscle field use C5b9. That's what we have, and I think that would be worthy of investigation. But on a practical level, I think C5b9 usually takes you where you need to go. But very nice question. Thank you.
Okay, I don't think we have time for any more questions.
Okay, thank you. Thank you again, everyone, for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation, which was just entered into the chat box. Completion helps ensure accurate reporting to the accreditation board. It may not display as a link, so please copy and paste it into your web browser if needed. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Margeta for an excellent presentation, and this concludes our session for today.
Thank you, everybody.